Greetings, everyone, ladies and gentlemen, and distinguished guests. This time, I'm going to talk about the static and dynamic navigation in clinical endodontics. And I'm Dr. Su. I'm from Kaohsiung Medical University. This is my portfolio. I graduated from the Chongshan University and have my master's degree in Kaohsiung Medical University, where I work in there. And I am the endodontic specialist and the operative dentistry specialist in Taiwan. And this is my YouTube channel. You can reach me in the social account. And today, this speech is about 30 minutes. So this one is the 1.5 hour online meeting where I talking about the static and dynamic navigation with the University of the Pacific Endodontic Study Club. If you are interested in this, you can see this video which upload on my YouTube channel. And this is today outline of today. I'm going to divide it into 4 parts. First part is the brief history of navigation, and the second part is the how does navigation works, and the third part is how about the accuracy, and the fourth part is the clinical cases. Let's begin with the first part, the brief history of dynamic navigation. The first navigation, we can call it the stereotaxy, is in 1898. And this one is a Russian doctor, maybe called Zernov. He used this about frame base to keep the frame on the human skull and try to do the stereotaxy. And then I may call the frame base technique like statics. And the stereotaxy come to the 1908. Which these two doctor is very famous in neurosurgeon. Horsley and Clark is these two doctor. They use like this one, like frame-based technology, and use the electroshock to make some lesion in the monkey head. But in this time, the X-ray, the radiographic, is still not invented. So we come to 1947. We have the X-ray. So they are going to use the X-ray, and they used the X-ray and the coordinate axis on the human skull, and then they will put people's head here. And like this, they will take X-ray and to try to locate where the neuron section want to go. And we come to 1983, where the CBCT it is invented. So they put this kind of frame on human and take the CBCT and try to guide the neuron surgery. And where that time the IBM personal computer was invented. So I think this kind of CBCT, it must be work with the computer. It must be used in computer. So after the technique was more mature, the frameless stereotactical neuron surgery was invented in so the frameless, which we can call it dynamic. Then this three square here is the camera, and they have some kind of tracker on the forceps, and they can locate where the neuron, the head, and in the CBCT position. And this is a steel station from 1990 to nowadays. So it's kind of a sonic base or some microphone array to locate and dynamic to locate to do some neurosurgery things. And to nowadays, this one is the stealth station today in 2020, ACE8. This kind of neurosurgery navigation is now still used in the hospital. So after we talking about the neurosurgery, this kind of technique, we can apply it into dental technique. So the 3D printed interact implant treatment, this one is the first, the earliest that which I can find in 1991. So in that time, we planned this kind of implant placement, but still not using the guided implant or some kind of dynamic navigation. So in 2000, we can see this kind of dynamic navigation, like this tracer and this tracer on the handpiece, on the mandible and on the handpiece. This kind of navigation is very, we can see is very like in nowadays the navigation we use. So we talking about the brief history of navigation. So let's see how does the navigation work. This is the digital dentistry which we used to do some veneer or crown or any kind of restoration. And this is how it works. In the reality, we have patient mouth, and we use the oral scanner to scan the geometry of the teeth into digital world. And after we do some design or do the crown design, veneer design, we use the CAD machine to manufacture the restoration back to the reality. So this is the digital dentistry will work. So how is the dynamic and the static navigation in endodontic works? We got the reality scale, we have the bone, we have the tooth, we have the root canal in the reality, and we use the CBCT and the oral scanner to take this kind of image into digital world. And after we done some design, we design the root canal pathway in the computer. We use the navigation and the 3D print guide like this or this kind of navigation to back to the reality world. This is how navigation works. So let's start with the static navigation, which is called is also called guided endodontics. So in the left, this one is the traditional guide. Which we all done this before. We use the vacuum and to put the vacuum on the wax-up tooth and design the restoration position and design for the implant position. Or we put some kind of gutta percha here and send patient to take the panography or take the CBCT. This is how traditional guide works. And after we have the oral scanner, and the oral scanner's market is very mature now, so we do this in digital. We use the oral scanner and the CBCT and put them together in computer. And we do the implant design and we produce this kind of 3D print implant guide. So the concept of the static navigation of endodontic is transform the 3D implant guide to 3D printed endodontic guide. So this is one of the paper published in 2016. They have the CBCT tools and the CBCT canal, and we oral scan it. oral scan the patient mouth, and we put these three image together and form this kind, and we design the 3D print guide and the metal sleeve, and which we use this guide to drill into obliteration root canal and finish the treatment. So this is the workflow of the static navigation. Take CBCT, oral scan, and put it and design it, and we use the 3D print to print the 3D printing guide. And this is the also can use in the surgical guide. Which we can use this platform here. We can use it to locate the apex of single tooth. And this is the different kind of. This one is with metal sleeve endodontic guide. And this 4 is for apical surgery. So this the picture A is this kind of surgical guide can keep the flap outside, and we can do the surgical more easier. And the image B in these two circles, we can directly use the tree fiber to remove the bone plate and do the apical, and also use the tree fiber to remove the apical. And the image C, picture C, we can see this kind. We can use the pilot drill, like implant pilot drill, drill a hole on the bone plate and locate the root apex. And this is also like this one. Picture D is also like the picture B, but with only one tree fiber access to do the single root. So we come to the dynamic navigation. And how is the dynamic navigation work? We use this kind of by block and with 3 radial opacity balls on it, and this by block patient bring this by block and to take the CBCT, and you can see it shows here in both 2D and 3D image. And we will fix this tracker, this QR code like tracker on the by block, and the camera here will capture the tracker and put reality and the digital world together, like this. This is the by block in CBCT, and this is a by block in the reality, and the reality and the CBCT communicate with this by block. And this is how the camera works. The dynamic navigation is like the GPS satellite. Well, if you are here, we got 3 your cell phone here, and we got 3 satellites in the sky, and they all send some kind of radio wave. And radio wave will reach your cell phone, like satellite number 1, number 2, number 3, and your cell phone got 3 of this radio wave, and they can position where you are. So the navigation, the dynamic navigation of endodontic is also work like this. This kind of LED light will hit the patient tracker here and back to the camera here, so they can know where the tracker is. So we have talking about how does navigation work. Let's move to the third part. How about accuracy? This one is the paper I published in the oral BMC Oral Health journal. This is about the static navigation. So it will become accurate when talking about accuracy. It will become different in deviation. You have deviation in coronal part and the apical part. The green one is the actual position that which I desire to go, and the red one is the actually in reality after I drill where I goes. So you can see the green one and the red one, it has some chronal deviation, and at the apex they have it has apical deviation. So these two drill will have some apical will have also angular gap deviation. So this is the research which I done. You can see in the this is pre-op, and this is the planning image, and this is the post-op, and this is the planning image superimposed with the post-op, and you can see a little bit deviation here. And this is the outcome. And there is plenty of research that published in both and IEJ and the JOE, both of a lot of research talking about this. And after I review all of it, I think the static guide, the average deviation is less than 1.5 millimeter, as less than 3 degrees in angular deviation. And talking about the dynamic navigation, this paper is comparing the dynamic navigation and the static navigation and the manually. So this is the outcome. The clonal is all. In this paper, we can see the manual navigation is less accuracy than both static and dynamic navigation. And the dynamic navigation and the static navigation is no difference between these two. And so the manual navigation is the worst one. And this also, we have some systemic review about the dynamic navigation, a lot of systemic review. So all of this research is a little bit different from the methodology, or the research design is different. So it's hard to say how much accuracy we can reach in static and dynamic navigation. So after I review all this paper, and this is my opinion of this, but it is not statistics. In non-surgical, we got about 0.5 to 1.5 millimeter deviation in apical area and 5 degree in angulation. In surgical one, we got about 1 to 2 millimeter deviation in apical area and 3 to 5 degree in angular deviation. Just about this. So for the record, you can, if you want to use this kind of technology, like static and dynamic navigation, you can keep this in mind. It's about this number of deviation. You have to look out of this. So we come to the 4 part of this clinical cases. So today we got 4 cases, both in static navigation and dynamic navigation. And both in these two type, we got non-surgical one and a surgical one, and also got non-surgical one and a surgical one in dynamic navigation. Let's begin with the static navigation with the non-surgical one. This one I got this osseous dysplasia cases, and we have patient has a sinus tray in the distal root, and we got a GP tracing. And in the right, this is the 3D reconstruction of these tooth, which I do. And after I remove the crown and try to do the endodontic retreatment, I found out that the mesiolingual canal was missed, and which I cannot deal with. So I planned the ML canal, mesiolingual canal was obliteration. So I put this green drill here and try to do the static navigation. And this is the CBCT. At the left is the original one, and the right is after I planned it. So you can see the green point here, green circle here is the mesiolingual drill pass, which I planned it. So you can see this tooth has both in mesial root and distal root with apical lesion. We can see the CBCT. We can see the CBCT again. Let's see left this time. Left one, we can see the crown and mesial root and distal root here. Mesial root and you can see the mesial root got the obliteration right here. Okay, so this is the planning image, obliteration here, and this is the drill pass which I designed, I planned it. And this is the surgical guide here, and this is in the software image, which the red rectangular is the drilling pass. And this is actual printed static guide with a metal sleeve on it. And this is the the microscope image. This way, here is the mesiolingual canal position, and this is after I have done the treatment. And this is the after remove the crown, and right one is the after I remove all the gutta percha within it. And I have found the full canal here, and this is root canal filling. And this is after the root canal filling. This is the mesiolingual canal. And this is the 3 months follow-up and 1 year follow-up. We can see the reduced size in distal lesion, but mesial lesion also the reduced size, but I think it's not totally healed. And the prosthodontic of our hospital, they already put a crown in it. But they didn't ask me. But if there is some problem furthermore, maybe I will do the I will do the microsurgery. And let's come to the static navigation in surgery cases. In surgery case, this one is the we have the patient has a sinus tract in the mesial root. And in the CBCT, we can see also the lesion in the distal root, but it's not very well defined in the apical radiographic. And we can see a lot of people may ask me that if this is a vertical root fracture, we also consider about it, and we can see the buccal bone loss in the mesial root. But you can see here is some gutta percha here, so we can find like a transportation in mesial buccal root, in mesial buccal canal, right here, and this is the transportation here. So I still designed to do the apical surgery, and I designed this kind of surgical guide. This is the 3D printed surgical guide. This is 5mm trifiber which I used. And in these cases, I also use the endodontic endoscope and the capsule. But I only use the capsule in this system, which is called AEROC. It's short in hemostatic endoscope root ends operation solution. It's invented by Dr. Tsai in Taiwan. And this capsule is for the this capsule is 6 millimeter in diameter. So I create the 5 millimeter cavity. So I trim this capsule here. And I do the mesial root and the distal root. And the mesial root, the lesion is bigger, so I didn't use the capsule here. And this is what I see in the surgical. You can see after I cut the root end, we can see transportation here. It's like it's in the mesial buccal area, and this is the mesial buccal root, mesial buccal canal, and this is the mesial lingual canal. It also got a isthmus here. So after I remove all the gutta percha, I link all these three hole together, form a line of preparation, and I fill it with MTA. And this is the distal canal, distal root apex where I surgical. This is the mesial buccal one, and let's see the distal root, which I use the guided, use the surgical guide. And this is where I drilling with drilling with the tree fiber. And you can if the buccal bone is intact, you can directly remove the buccal bone, and the buccal bone will be placed back later. And we can keep drilling and remove the apical part of this root, which got the gutta percha inside and some graduation tissue. And I put this kind of capsule for the apical surgery for the hemostasis, and can keep the contamination out of the bone cavity. And I do the retrograde preparation in the apical the distal root. And we do the MTA feeding after after the root end section and the retrograde preparation. So you can see if we use this kind of capsule, the blood will be kept outside. Or if the blood is still if it's still bleeding, you can suction from the capsule margin, and the blood will be sucked out. And this is the after MTA feeding. And this is the mesial root and distal root where I cut it. You can see this is part of this one is go to the transportation in mesial buccal canal, and this one is mesial buccal canal. And this is the mesial lingual canal. This is the distal root. This is the post-operative. But this one I still got no follow-up X-ray. So we come to the third one is the dynamic navigation in non-surgical cases. And this one is this patient complained about the very long term, about 5 to 6 year long-term tooth soreness over these tooth. So luckily, this patient is followed up by the perio department in our hospital, and the perio department keep take the X-ray to follow the perio condition in every tooth. So this patient have done this amalgam restoration and the IRM aligning under the amalgam restoration. We can see in 2014 still got root canal here, and it's more with the time passing by. The root canal is more and more. You cannot find root canal in this X-ray, and I think the pulp is shrinkage or squeeze to where you really cannot find it, and also the root canal may be more classified, and we got the root canal obliteration. So this one we got the 237 the canal obliteration. and we try to open it, but I cannot find the root canal. So this is the 3D reconstruction of these tools. Here is the resin, and the space here is chamber, which I opened. And here the more the yellow one is the Vitapex, which I put. You can see I'm almost going to perforation here. I drilled to here to this deep, but I cannot find root canal. So I put some Vitapex here and send patient to take the CBCT. And we can see the CBCT 2D image here. And let's see, this is crown with resin. And this is chamfer, which I opened. And this is the Vitapex. And you cannot see canal here and emerge here. So you can see that I drilling on the round place. And this is the apical fragment, the root canal here. So it is a C-shaped root canal. And this one is after I planted it. I planted these two paths. This blue circle here is which I drilling with these two circle to reach the buccal, which are mesial and the distal canal. But it emerged to only one root canal here. So this one is the video I actually do in dynamic navigation here, and I'm drilling to the mesial canal within this C-shaped root canal. And this X here is X guide navigation. And you can see this kind, we drilling it, when you pass it through, it's too deep, it will show the red circle right here. So here I reach the distal root canal. Okay. So this is after I perform the root canal, perform the root canal canal shaping, and I fill it with the 1 gata per chart technique. And this is the 6 months follow-up. And the last one is talking about the dynamic navigation in surgery. This is the dynamic. This is a very long post here. I think this is very hard to remove the post long like this. And if I cut 3 millimeter in the root apex, then I do the retrograde. The whole space may be filled with MTA here. So I didn't remove the crown and remove the post. This is the planning of the mesial root. I also put a tree fiber here, and this is the distal root. And this is an image that I actually drilling using the dynamic navigation in surgery. And we can skip to the last. So this is after I drilling. I remove the bone plate here, and I remove the bone plate and put it in normal solid. But you can put it in HBSS. I think that's better. And I will put the bone plate back. And this is the root apex. Root apex, which we remove it with the tree fiber. I always ask patient to buy this tracker in surgery, and buy the tracker make the tracker more stable when you do the surgery. And this is the mesial root, distal root. And I remove also the isthmus inside the distal root and fill it with MTA. And this is a bone plate replacement. This is after I remove the root and I place the bone back to do like the window technique. This is a post-operative. And I got 3 months follow-up. The bone place I think is going to grow back, and 6 months is rarely can see the apex, the lesion, and this is after the 1 year's follow-up. You can see total heal with bone. You cannot see lesion anymore. So this is the tool I think for the root canal obturation, and I count the dips from the occlusal plane. So if we use the naked eyes, we can see about 5 to 8 millimeter from the occlusal plane. And if we use the loop, when you find the canal obturation, the loop can reach maybe 8 to 10 millimeter from occlusal plane. And if you use the microscope and the canal is obliteration, you maybe reach about 10 to 12 millimeter in microscope. And if you use the static guide, because the guide has a thickness, so maybe you can only reach about 30 millimeter in from the occlusal plane. But if you use the dynamic navigation, you can reach the 60 millimeter from the occlusal plane. And this is and the -3 millimeter is for apical surgery. And this is the software you can use in static navigation. All kind of this is all can use. You can all design the surgical guide with like the blender for dental, or the famous Exo guide, or the famous 3D implant studio. And this interware is which I used, and the blue sky plan is all can use. You can use it in the static software. And this is the 3 kind of the dynamic navigation I have used. This is they have some different here. But I think the most different, all we can use this 3 kind of navigation with high speed, low speed, or motor. But we can use I think that if you are doing the non-surgical endodontic, you use the navigation, and you navigate can use the ultrasonic tip, and the EPAD is also can use the ultrasonic tip, and it has some different here, but I'm not sure. It's not so different. And we also can buy this. We also can buy this Stang X in Taiwan, and this decar is manufactured in China. And this is the take-home message for the static navigation. Difference between the static navigation and the dynamic navigation. Generally speaking, the static navigation is hard to plan and easy to execute, and cheap. Planning takes times, and you can use low speed ultrasonic, but you maybe you cannot use the high speed for the static navigation. And the speed is too high, it will generate heat, may melt or damage the guide. And it cannot change real time. Obviously, it cannot change real time. Easy to correct off track. If you the guide is off track, you can easily put it back in back to the tooth. And the guide design should consider rubber coverage, because you use if the guide is more big, it may affect your rubber coverage. So, and generally speaking, in the dynamic navigation, it's easy to plan but hard to execute. It may take another technician to help you to execute the surgery or the dynamic navigation. And it's expensive and fast. You can patient come to your clinical, you can send patient to take CBCT, and right after the CBCT you can begin to execute. But you cannot do that in the static navigation. You can only very fast in the dynamic navigation. And obviously, the dynamic navigation can change real time, and it takes time to correct off track, because if the by block in patient mouse is off track, you have to redo the registration. And in non-surgical endodontic, the static guide restrict by the guide thickness, so it can only down to maybe 10 to 13 millimeter from the occlusal plane. And the dynamic navigation, the non-surgical endodontic, it don't obviously don't have the no guide thickness, and so it can down to 10 millimeter to 16 millimeter from the occlusal plane. And so this is one of the dynamic navigation in non-surgical endodontic. It got some advantage in posterior tools. And in static navigation, we got if the apical surgery, the surgical guide can retract the flap, make the drilling easier. And the dynamical navigation may be drilling on the angle, make more difficult to align. So this is all the speech today. And after this, I have the bonus here. This is one of the fail case in dynamic navigation. You cannot find in this case I cannot find the MBML, the distal canal, although it's right there, but I cannot find it. So after I open these tools, I cannot find the mesial buccal and mesial lingual canal. So I put some Vitapex here, radiographic medication here, and radio opacity medication here, and I take an X-ray. So I can find that I'm not in the right path. So I send patient to take the X-ray now, to take the CBCT. So we got the mesial buccal root here, and we also got the distal lingual root here. But the distal lingual root, we rarely can see the root canal inside. So I do the dynamic navigation here. And I'm checking the verify the accuracy. I put the tip on the tools and check if the if it is good after registration. And I located the mesial canal directly because it's very easy. And in this APEC software, we can put a microscope image here. And this is where I drilling to reach the distal lingual canal. But the distal lingual canal, you can really see it in the CBCT. It's almost, you cannot see any canal there. So I keep trying, but I failed. So after this drilling, I still cannot find the distal link. After I use dynamic navigation, I still cannot find the distal lingual canal here. So I fill in another 3 canal and finish this case. So this is one of the failure case of my dynamic navigation try. So I think it still got some limited in dynamic and static navigation. So thank you all to listen this speech here. And don't forget to subscribe my channel. Thank you.